Recording.
Completed her pharmaceutical. Got it, it's recording. She completed her pharmaceutical sciences degree at University of Lisbon, where I graduated from as well. She also holds a postgraduate degree in leadership from the American Pharmacy Society of the Unified Health System and a postgraduate degree in health management at the Portuguese National School of Public Health. She's a practicing pharmacist at her own community pharmacy and also serves as the general manager of Ezfy, which we will learn much more about during her talk. She is president of the Portuguese National Association of Pharmacies, and she's held, you can see in her bio, multiple other positions. I think I am right in saying that Ema is probably, or I think surely, the most famous pharmacist in Portugal. So we are very lucky to have her. Welcome, Ema, and I'll turn it over to you. Thank you.
Thank you very much again for your kind invitation. And it is for me a pleasure and an honor to be presenting to you today. So hopefully I will be talking about something innovative that we introduced in Portugal a couple of years ago, just before the pandemic really hit. We found it also important to cope with the changes and the acceleration of changes that we needed to implement in pharmacies in Portugal during this period. So I will present to you this project. It's called Ezfy, and I will introduce you to the context first. And then I will be talking about some of the programs that we have been conducting and also some of the results. And hopefully we will still have time for your questions afterwards. Okay, so there is some information about claiming credit for this presentation. So please refer to this information on these 2 slides to submit attendance, and also the information to complete the evaluation and claim credit. So hopefully you have got that already. So you have here the course code for this event. Then some information about the seminar today. I will have a separate slide about the objectives of today's session, and then some assessment questions, which I will ask you at the beginning of the presentation, and then at the end of the presentation for you to see whether well you got it first right at the first time. So as for, I did not mention, but in terms of financial relationships and disclosure of any conflicts of interest, I have some of the programs that I will be presenting are sponsored by the pharmaceutical industry, but they have not influenced any part of my presentation to you today. So for the learning objectives for today, hopefully at the conclusion of this activity, you will be able to review changes in healthcare delivery that likely impact pharmacy practice, or at least some examples of that. Describe current trends in contemporary pharmacy practice as they relate to interprofessional collaboration. Also to discuss practice innovations designed to improve health outcomes. I will hopefully talk to you mostly about this today, and discuss role delineation for pharmacists on the interprofessional healthcare team. So I have some questions for you. Hopefully you will be able to get them right at the first time, but if not, at least at the end of the presentation, yes. So first question, which of the following is not true regarding patient health journeys? So that they are often complex, that patients engage with multiple healthcare professionals. There is only one contact point for healthcare, and health provision is often not integrated amongst the different healthcare facilities and professionals that contact with the patient. So this is the first questions. So the next one. So technology adoption in community pharmacy has been accelerated by the willingness of healthcare professionals, the expectations of patients, COVID-19, and all of the above. So I will not give you the answer right now. I will give you the answer by the end of the presentation. Third question, which of the following is not true regarding community pharmacies? And with community pharmacies, what I mean is those pharmacies that have their doors open to the public. That's the terminology that we mostly use in Portugal. So they are highly accessible to the population. They often do not have time for patient care. They have highly trained professionals. They have convenient opening hours. So again, please keep your answers to yourselves. I will not give you the right answer right now. And then pharmacy can document various kinds of patient information. Which of the following should not be reported? So patient self-reported outcomes, caregiver reported outcomes, team member documented via assumption or patient conversations, and none of the above. So I will now go into my presentation, which begins with how we see the situation right now. So, and what was the beginning of our project in Ezfy? So we believe that the patient journey can be very often overwhelming, and we have multiple contact points for patients. And these contact points nowadays can be healthcare professionals, but they can also be Dr. Google or even social networks where people engage with other people and they engage in conversations about healthcare related issues and diseases and treatments. And so very often patients are very confused and they source information from multiple locations. So in a way, what we can say is that having a chronic disease can be difficult and complex. And we talk specifically about chronic diseases because these are important, because nowadays we have people that with the increase in life expectancy, they live longer with disease than without a disease. So it's important that people learn how to cope with a chronic disease, but that is not often very simple. We need, therefore, solutions that make lives of patients with chronic conditions easier. And we believe that an easier life means a simplified access to health solutions. So the project Ezfy, it's meant to be a verb, making health easier for people, particularly people with chronic health conditions. So basically, our motto is health made easy. So our mission is to use innovation and technology to think, create, and implement solutions that simplify and facilitate the health journey of the person with chronic illness. And I will be explaining how we do that in the next slides. So basically, our value proposition is to help make certain chronic conditions and all chronic conditions simpler and easier. And so we design interventions that easify people's diabetes, people's hypertension, multiple sclerosis, or whatever chronic disease they're dealing with. And we want to make it simple for people and also for healthcare professionals who are delivering care solutions to these patients. So how do we see the situation now? I've already mentioned the patient health journey is frequently complex with multiple contact points, which are not always interconnected or integrated. So, but changing this paradigm is in fact being accelerated by the fact that patients themselves want to be more involved in healthcare decisions. There is an increased emphasis on health outcomes as a part of access and reimbursement negotiations. And of course, this gives us an opportunity to interact with specifically the pharmaceutical industry, because they are interested in collecting health outcomes. And we also have seen a growth of specialty drugs that require additional patient support, such as administration or helping titration or other types of counseling, like for people to learn how to use, for instance, inhaler devices. So there are a number of initiatives and interventions that must be delivered in order for patients to take maximum benefit from the medication that they are taking. So where is the opportunity? I've already mentioned the willingness of pharmaceutical industry to collect data on health outcomes. And this is because real world effectiveness and safety will be and are already driving regulatory decisions. And by regulatory decisions, I mean access to the market itself, but also how drugs stay in the market if they're being delivered in community pharmacies, if they are being only delivered in hospital settings, and the type of risk management programs that they have to have, and obviously also the effectiveness of the drug and the safety of the drug also is linked to the amount of money that the governments and the insurers are available to pay for a certain drug, and also obviously what patients themselves are willing to pay for the drug itself. So we have seen risk-sharing agreements being increasingly established. I don't know if you're familiar with risk-sharing agreements, but basically they are agreements between the pharmaceutical industry and insurers, or pharmaceutical industry and governments who pay for the drugs. And basically what is negotiated is if a drug does not have the effectiveness and safety that is negotiated at the start, like a service level agreement, let's say so, a certain percentage of effectiveness, for instance, the pharmaceutical industry has to pay back to the government or the pharmaceutical insurer the money that they have invested in the drug. So we are seeing a lot of these risk-sharing agreements being made. And I will give you an example that happened in Portugal some years ago when we had the new drug for hepatitis C. The government established a risk-sharing agreement with the pharmaceutical industry, and they only paid for those patients that were cured with sofosbuvir. So for any patients where the drug was administered but did not cure hepatitis C, the government did not pay the pharmaceutical industry. So this is an example of risk-sharing agreements. So, and why is this an opportunity? Because, okay, we have a need from the population because we have chronic conditions, people need support. And we also have possible financing for services that can help us with this need, because there are people who have the financial resources to support healthcare professionals that are interested and willing to provide solutions to these patients. So this is an opportunity for us, namely the pharmaceutical industry, to get financing for our activities, which we believe can help increase medication effectiveness and safety. So how do we see the solution? So we see the solution through programs that are implemented by pharmacists. And these programs will, in one hand, shorten the time to get patients on medication. I will talk to you about this important part of the patient journey, drive adherence and positive health, clinical and quality of life outcomes. And they also differentiate the brand by delivering an improved consumer experience. Obviously, different diseases need support at different stages of the disease progression. Some may need support sooner, and some later, and some throughout the entire journey. And I will give you some examples of those. How are Ezfy patient support programs? Well, basically, they apply strategies to support a healthier lifestyle and monitor and improve adherence to medication. They are personalized, they are continuous, they are data-driven because they collect evidence, and they are grounded in behavioral science. So we look at aspects that can have an impact into why a patient would be adherent or not to the therapy, in order to provide the support that people need to be willing to take better choices about taking their medication as prescribed. So they are predictive, adaptive to patient expectations and preferences. Some of our programs, for instance, we have the possibility for patients to choose if they want to receive medication alerts, and if they want to receive medication alerts, whether they want to receive them by email, by SMS, by WhatsApp. They can also choose to have, for instance, consultations with the pharmacist to teach self-administration of the medication, and they can choose to have it in person at the pharmacy or via video consultation. So we have multiple choices within the programs, and patients may choose how they want to interact with the pharmacist or with the nurse within the programs. And they are also integrated into care pathways. For pharma, like I said, they represent a revolution in insights based on real-world effectiveness and safety data, and provide critical evidence base of improved outcomes that payers and societies will increasingly demand and expect. Payers and society, they are investing a lot in medication, so they want to know what they are actually getting in return. So how do we implement our programs? Well, what we do at Ezfy, we have a team of pharmacists and one nurse. And what we do is that we engage and recruit trained healthcare professionals who are a perfect fit for these programs. And we have, within our programs, we work mostly with pharmacists, and I will explain why. But we also have nurses, dietitians, and psychologists that participate in some of our programs, depending on the disease and the needs that patients have. What we do is we help to design the necessary protocols and provide medical writing support. If we are, for instance, conducting a program like we have one for heart failure, we are applying a validated questionnaire for quality of life for people who have heart failure. And we do that every 6 months in order to see whether patients' quality of life is in a way getting better or how it's evolving. So we are accountable and liaise with partners for regulatory and legal framework on the various project components. Anytime that we need to submit, for instance, some kind of need for an ethical committee evaluation on our projects, we do that and we prepare that. And then we develop and implement innovative solutions, such as smart applications, websites, connected tools, blogs, and we have a call center with a nurse that people can call. So depending on the disease, the needs of the disease, we may need different kinds of solutions for people. So we customize each program depending on the needs. We also, the Ezfy team manages the day-to-day by appointing a dedicated project manager and providing the appropriate tools. And we use, I will be speaking about that later, we use Salesforce Health Cloud, which is the component of Salesforce, which is the biggest customer relationship management software internationally. We use the application for health from Salesforce to design, to register, and generate project follow-up data. I will mention this a little bit later on. So where have we started? So obviously, when we are talking about different kinds of diseases, and if we are to also impact in terms of the early stages of the disease, and very often when people even don't know that they are ill or that they have a certain risk for a certain disease, pharmacies in Europe are a great infrastructure or are a great healthcare facility for that, because whereas in the United States it is allowed to have OTC products available to the public, in most European countries that is not possible. So in community pharmacies in Portugal, patients who want to access any OTC medication, they have to talk to a pharmacist first. So they're all over the counter. They cannot be directly accessible to the public. So this presents a number of opportunities for the pharmacist to assess what are the complaints the signs and symptoms for the different diseases, and they can be alerts for certain diseases that are not diagnosed, and people keep treating signs and symptoms with certain medication, but what they should be having is an early diagnosis for a health condition that they have to treat with prescribed medication. So community pharmacies in Portugal were an obvious point of contact for these reasons, because we are present at the very early stages of people's lives, because people go to the pharmacy quite often, even more often than they go to the physician. And of course, from the moment that people have a diagnosis, they get their prescription medications from the pharmacy. So it's also a good opportunity in those dispensing moments to evaluate therapeutic effectiveness and safety, and also to provide health information and give education to the patient on how he can best self-manage the disease. So we have started with pharmacies as Ezfy points that are meant to simplify people's health journeys. So we have more than 130 Ezfy points. Portugal is quite small, so we have these 130 points distributed throughout the national territory. In Portugal, we have around 2,900 pharmacies in total. So this means that we have approximately 5% of pharmacies already engaged in this initiative. We have more than 800 healthcare professionals that are already engaging patients in these types of programs. And we've had more than 21,000 participants already in different programs since March 2020. So where are the Ezfy projects? As I've mentioned before, given that the pharmacy is often located in the different stages of the patient journey, from pre-diagnosis to normalization of the disease, actually Ezfy projects can be in all of these different stages of the patient journey. They can be on the pre-diagnosis, and if it's on the pre-diagnosis, usually what we have the opportunity to do is make health promotion and disease prevention, but also to identify people with signs and symptoms or risk factors for certain diseases, refer them to the physician. What we do in our programs is that we provide follow-up for those situations where we refer the people to the physician in order to ascertain whether people have gone to the doctor, if they've been in a physician consultation, if there was a new diagnosis, whether any therapy was instituted, and if a therapy has been initiated, what kind of therapy. So when we work in these pre-diagnosis stages, we want to follow up on our intervention. We just do not only refer to the physician, we want to know what happened after we referred the patient to the doctor. Also, we have had programs in pre-diagnosis, well, similar to pre-diagnosis, but for people who have been diagnosed. What do I mean with that? For instance, patients who have migraines, and they may already have a diagnosis, and they usually take some medication that they get from the pharmacy, from the community pharmacy, for migraines. But if we, at the moment of dispensing, if we assess the effectiveness of the medication and people still continue to have more than 6 migraines a month, that means that the medication is not being effective, and we should refer that person to the doctor in order to make another evaluation, because as you know, possibly know, there are biologic medication which are better preventive medication for these people who have more than 6 migraines per month. So these are examples of situations where we can work in terms of the pre-diagnosis. And this is quite important because, for instance, we know that for some diseases, people can be up to 10 years with symptoms and they're self-medicating, and they do not have the right diagnosis. We have examples of that in, for instance, Crohn's disease or inflammatory bowel disease, where people just think that they have some issues with certain foods, but they actually have a disease that has to be treated in some way. And the same, for instance, for ankylositis spondylitis. I don't know how to say this in English, but the average time between the first symptom and diagnosis is usually 10 years. 10 years, because people keep self-medicating with analgesic drugs. So this is quite important, to be proactive and to address people who are taking too much OTC medication, and we should assess them and formally and refer them to the physician. Then we have programs for which pharmacists may have the opportunity to intervene directly and to counsel and dispense certain medication. For instance, smoking cessation, where we have non-nicotine replacement therapy, which is available for pharmacists to dispense, or any other types of conditions, healthcare conditions, for which the pharmacist has the authority to prescribe or to dispense certain medication. And we have programs also in these circumstances, and what we do in these kinds of programs is what we dispense the medication or the healthcare products that we think will help the patient control the disease, and then we provide follow-up consultations over time to assess the effectiveness of the counseling that we made, and to eventually adapt the therapy or the dose according to the control of the disease. And then we also have programs that are provided to patients that have been prescribed certain types of medication. So for instance, I've already mentioned heart failure. So we have a program for heart failure for a certain medication. And what we do is, when we have a person coming into the pharmacy with a prescription for that heart failure medication, we invite them to participate in a 12 months program. And this 12 months program is designed to monitor adherence and to promote adherence, to help people identify signs and symptoms of disease decompensation, for them to know when to seek urgent care. And in each visit that we have, and we have a visit every 2 months, in every visit we have a topic that we will address with the patient. For instance, the importance of having a caregiver, the importance of pneumonia and flu vaccination, the importance of maintaining some kind of physical activity, the importance of nutrition to control heart failure. So in every visit we have a specific healthcare subject that we will address with the patient, and this 12 months program is designed to increase people's to empower people to take better care of themselves, because they have a chronic condition that they will have until the end of their lives. And we also have programs that are they are continuous. We only cancel them for patients who do not want to continue in the program. And we have programs designed for multiple sclerosis, for instance. And what we help people with in these programs is to, for instance, to teach them how to use the self-injector pens. We help them to cope with the progression of the disease. We also, if the medication needs titration, we help with the titration. If the person is experiencing some adverse effects or adverse events, we give strategies to cope with those adverse events, or if they're too much for people to handle, we also refer the person to the physician for re-evaluating the therapy. So for all these stages, like I mentioned, we have had Ezfy projects, and these are dependent on the disease characteristic and what we want to do with that situation in particular. What we have done because I told you that the programs, they are implemented and they are offered by the pharmacy teams, so they are offered in community pharmacies. So what we do at Ezfy is that we, like I said, we have a team of pharmacists who give education, and they train and they constantly motivate pharmacy teams to be able to deliver these projects. And we have a website where healthcare professionals from the pharmacies they can go into, and they can access all the different programs that we have. And they can also access any events that we have organized around different topics like diabetes, or any trainings that we've provided connected to the programs that we deliver. We also have a presence on social media, so we are on Instagram and Facebook, and we basically we promote the types of programs that we have in the pharmacies, and we also have posts about healthcare diseases in general, and the healthcare awareness and education in order to empower patients to take better care of themselves. And this is just an example of a post that we've done on multiple sclerosis. And then we have the patient, or the Portuguese patient organization for patients that have multiple sclerosis, disseminating the information about our program, and thanking pharmacists for what they are doing for multiple sclerosis patients that are engaged in these kind of programs. So what we also do is that we, when it's pertinent, we also develop some materials like leaflets for pharmacists to hand over to patients with information about the disease or information about the therapy. And we also provide them with some videos that they can share either on social media or in their pharmacy windows, because we provide pharmacies with window displays, electronic window displays, where they can, where we put videos about our programs and about the different diseases, so that they can also, well, promote the services that they are developing. So how do we make sure that the pharmacists are able to do this? We know that community pharmacy teams are very busy all the time. In Portugal, people expect to go to a community pharmacy with a prescription, and 5 minutes later they're out the door with the prescription medication. And there is a lot of traffic in community pharmacies overall. So we had to develop a tool for community pharmacies to be able to register patients in the different programs. But then what the tool does is that it prospectively plans all the interactions for the patient according to the program that we designed. And the program will let the person know in the pharmacy, the person that is responsible for following up a certain patient in a certain disease. The system will alert the pharmacist that a new consultation is due with that specific patient, or a new intervention is due, and the platform guides the pharmacist in what he has to do. Is it teaching about the auto-injector pen, or is it about increasing the dose of the medication, or is it about applying a questionnaire about assessing quality of life, or is it about adherence? So the platform guides the pharmacist in the intervention, and it's also in the platform where the pharmacist can register the intervention and can record patient data. what we then do at the central level, so at the pharmacy, this tool is used as a point of care tool where pharmacists will record the interventions and they will be able to access at any time the information about in which programs the person is being followed up, in which what is the status of each program, what was the situation in the last consultation. So this is a point of care program, but at the central level, what we receive is anonymized data about all these interventions. So what we get at the central level is, like I said, anonymized information, so following all the data protection legislation, but then we are able to perform studies and to evaluate the effectiveness of the interventions, and also we are able to follow up over time, in real time, the number of patients that are included in the different programs and how the program is being run. So I think that I will share again, because I don't know if I was sharing my screen, but okay, this is the actual login to the platform, the central platform. So this is all real data, but you will not see any patient related data. But this is the platform where we can see that over 21,000 people have already been integrated in one of these programs. Here you can see the age distribution, here the sex distribution, mostly female. The number of pharmacies we already have with programs, 131. Each pharmacy has an average of 160 patients that they have integrated in Ezfy programs, but we already had one pharmacy that integrated 1,413 patients. That is the maximum number one pharmacy has already achieved. So this is the number of patients that are nowadays being followed up. And we have, so this is the general dashboard, but we also have dashboards for the different programs. So for instance, I will show you a program on chronic venous disease, I don't know, circulatory disease. So this is a program that we launched in April. This is for people who present with symptoms of tired legs at the pharmacy and may have circulation problems. So from April until now, this is the number of registrations in the program. So we had 62 in April. This was we launched the program, I think it was on the 16th of April. So this was the number of patients. And now in May, we already have 141 patients that have been integrated in the program. This is the total number of patients. And then this is the total number of pharmacies that have registered patients. Again, this is the sex distribution. So we are able to, with this platform, we are able to generate real world evidence about what we are doing in the pharmacies. And that's the last of my presentation, is actually about some of the results of some of the initiatives. So for instance, Ezfy developed a service to support patients taking a medicine to treat a long-term condition for the first time, which is the new medicine service. So what have we found out from this program? We have at this point, we had already included more than 11,000 people. And what we know is that 10% of patients after 1 to 2 weeks are no longer taking their medicine as prescribed. So 10% of patients, 1 in every 10 patients, is not taking the medication as prescribed even 1 week after it was prescribed or initiated. So this is an opportunity for pharmacists to recognize the important role that we have on patient adherence. This was another project to fast track the patient journey to irritable bowel syndrome diagnosis. So patients that presented at the pharmacy always buying OTC medication for abdominal discomfort. So in this patient, we assessed the symptoms to understand, applying a Rome questionnaire, and we evaluated, and if the person presented to us with the characteristics of someone that might have irritable bowel syndrome, we referred the patient to the doctor. So we sent basically 475 patients to the physician, and actually treatment was initiated in 25% of those patients. So very important intervention that we had in terms of referring people to the physician for a diagnosis. And lastly, our program on smoking cessation. We had very good results. You might know that without healthcare professionals follow-up or intervention, a person is likely to be successful after 3 months. For smoking cessation is approximately 12% of success. In our program, at 2 months, 69% of patients were sustaining smoking abstinence. So really big results in terms of the support we gave to these participants for not smoking. So to finalize, and before we have, maybe we have some time for questions, well, just to give you the answers for the different questions. I think I will go to the other ones because these ones are already signaled with the response. You will get those slides later. But here we see which of the following is not true regarding patient health journeys. So they are often complex. Patients engage with multiple healthcare professionals. There is only one contact point for healthcare. Health provision is often not integrated. So the correct answer here is there is only one contact point for healthcare, because obviously there are many. And this is why we have this the need for us to intervene and also to be integrated into other levels of care. So technology adoption in community pharmacy has been accelerated by the willingness of healthcare professionals. Well, if they are not willing, then there's a problem. So obviously, if we had any adoption, it was because healthcare professionals have been willing. Patients also expect this, and definitely COVID-19 has accelerated that. So all of the above. Which of the following is not true regarding community pharmacies? So you might think that they often do not have time for patient care. Well, this is not true. So B is the correct answer. We always should and we have to have time for patient care. Otherwise, why would patients not get their medication through a dispensing machine? So it's really about patient care, and we should not use the excuse that we do not have time to provide what is the most important thing for us to be providing to patients. And pharmacy can document various kinds of patient information. Which of the following should not be reported? I haven't talked a lot about this, but obviously we connect information from all the sources. So actually none of the above, or we should report all of them, and we should register all of them because they're all important sources of information for our interventions. And that's it for my presentation. I'm sorry for being a few minutes late and therefore finishing almost on time. But hopefully if you've had also any questions that we are not able to answer during the time that we have, Madeleine or Teresa are most welcome to provide you my email so that I can follow up on any questions you may have.
Thank you, Emma. This was outstanding. Any questions at this point, feel free to unmute yourself or drop them in the chat box. I do have a question, but I want to give other people opportunity since I have had the chance to speak with you offline. But we have our first question from Tyler. You mentioned that in Portugal, for patients to buy OTC products, they must first speak to a pharmacist. This is probably wishful thinking, but do pharmacists in Portugal receive either reimbursement for their time or a percentage of the sale to compensate for their efforts? It seems like a lot of time would have to go into providing OTC medications, the pharmacist workflow.
So the reimbursement system for medications in Portugal is based on margin, on price. Pharmacies are paid based on the medicines that they dispense, mostly. So we've just had a different service. We do have a different service, which is the COVID-19 testing, and that service is paid by the national healthcare system. So for that, we are paid directly a fee for the service. But the other remuneration model that we have is based on either the margin on the product or a fee for the service that is paid out of pocket by patients. So patients often pay for blood pressure measurements or injectable drugs or for the administration, immunizations, etc. That's how the pharmacies are reimbursed. And the margin that has been established for pharmacies for the dispensing of medication assumes that the pharmacist will be dispensing and will be counseling the patient on every dispensing. So actually that margin and that reimbursement fee assumes that there is counseling. So yes, it is paid for. In terms of the pharmacists themselves in the pharmacy, they are paid with a salary, and it's the same if they sell more or less. Well, some pharmacies may have some system of prices or some connected to the provision of care, but the most common model is just a fixed salary. But this is basically what is expected from pharmacists. It's this counseling and this approach to the patients.
Yeah, great, thanks. Because that's not really how things are done here. So it's cool to kind of see that you are being paid in some way, shape, or form, paid back for that time of counseling on those those medications, because here patients walk in and they just grab them and then they leave. So even if I was to even if I was to talk to those patients, you're not getting paid for that time. It isn't built into our model. So that's really neat. Thanks.
Hi, Dr. Paulino. Great presentation. I want to thank you for creating an organization that allows for Portuguese pharmacists to practice at the top of their license. I was really impressed by the services that you provide to the Portuguese population. My question has to do with, actually I have two questions. So one, if you could clarify or just explain a little bit better. I'm sure you did. I was just not paying 100% of my attention to the payment model. Just quoting someone else, no margin, no mission. So with Ezfy specifically, what is the essentially the money-making mechanism to allow pharmacists to have more time to do this?
Yes, and I'm sorry, I did not mention that specifically in my presentation, and it's a very important point. For Ezfy pharmacies, for every intervention, we pay for community pharmacies. And for community pharmacies are paid either by consultation or by a program that is completed. So for instance, for smoking cessation, we paid for the whole program, and we paid an amount of €60 for the initial in-person consultation, and then the 3 follow-up telephone contacts. So for every program, we establish the remuneration for pharmacies. So basically, we procure this remuneration from the pharmaceutical industry, and then Ezfy pays the pharmacies for the services that they are providing, so that these services can be provided to the patient free of charge.
So to follow up on that, so it seems to me that the income opportunities from Ezfy are mainly from the pharmaceutical industry as of now, right?
Yes.
Do you think by incorporating other services, for example, if the idea is to improve medication adherence, most of the chronic patients are also patients of different diseases. So if you guys incorporate, for example, services like medication synchronization, because you already have the appointments, so it's just a matter of synchronizing all the medications for that patient, do you think there's an opportunity for the National Health Service to recognize the value of those services, and therefore you expand your income revenue opportunities?
Yes, most definitely. And that's what we are trying to achieve, is that, for instance, for the new medicine service, the one that assesses medication adherence after 1 week and then after 2 weeks after intervention, it is being sponsored by Ezfy. So it's not the pharmaceutical industry. We, as Ezfy, we are investing in that service. We are paying the pharmacies. And we want that to collect the data to then go to the NHS or to healthcare insurance companies in Portugal. These are voluntary, but they are covering an increasing number of individuals. So we are going to them with data already saying, well, this is happening. This is important for people not to end up in emergency rooms. So we are able to provide this service that decreases non-adherence in such and such percentage. So will you be willing to pay us for the service? Yes, definitely. That is our ultimate goal.
And have you found that there's openness from the private insurance and the NHS specifically to pay for that?
I think it would be easier to get it from the private insurers first. We are hopeful that that will happen, and then we will attack the NHS.
Yeah, it's a different animal. Thank you very much.
Exactly.
I think we have a question in the room. Let us know if we can hear.
Thank you for the excellent discussion. My question is that some of the things you discussed, using an example, hepatitis C. Most of our hepatitis C drugs in this country come from a specialty pharmacy based on the patient's insurance. So that specialty pharmacist would call to the patient to educate them in addition to the provider's service. And so that sounds like something that like Ezfy is trying to do, where some of these medications come from a specialty pharmacy and can't come from the community pharmacy. Can you comment on maybe the variations, or is that correct, that what's occurring in Portugal versus what's occurring in the US?
So in fact, in Portugal, as in other European countries, we already had companies that were providing that or insurance companies that were building inside teams to do that. What we are telling them is that it is more cost effective to do that through community pharmacies, because we have the opportunities to intervene. We have the locations. People think that we are highly accessible. Many things we are not able to do via phone. There is a need for glycemia testing, for instance, or showing the person how to do the injection or any other service. So what we are trying to do is basically to put community pharmacies in the solutions. We are not saying that we want to substitute everything, but we think that for some of the programs and for some of the services, we are more cost effective, and we have the biggest opportunities to intervene in an early stage and to give in-person services, because we are closer to the population and they don't have to go to the hospital, or they don't have to go to the healthcare building. So in fact, we had already many companies in Portugal that were providing this kind of patient support programs via call centers, etc., via nurses specifically. What we are trying to do is tell them that that doing it through community pharmacy is an alternative and is a wise alternative, and it is a cost-effective alternative. I don't know if, because I didn't hear the question too well, I don't know if I replied, but I sense that you were asking about those, because I am familiar with, for instance, the patient care that they provide in Kaiser Permanente, etc., where they have a lot of also pharmacists calling people to aid them in the titration of the medication, etc. What we are saying is that we can do that for them via community pharmacies in a cost-effective way, and given the opportunities we have to interact with the patients.
Thank you. It was just more about some of our drugs in this country have to come from certain pharmacies. And so as a person who wants to educate and interact with the patient, sometimes we do it on the side as well, but we also have a specialty pharmacist who's remote at a specialty pharmacy who's also doing the titration and interacting with the patient as well. Drugs such as hepatitis C all have to come from specialty, most of the HIV medications. And so it's just, you know, if that can be coordinated at a community pharmacy, that would be excellent. But sometimes we don't have the ability actually to make that choice because the insurance company tells us what to do.
Yes, and I understand that. And tell you in Portugal that we do have some situations where we are coordinated with the pharmacy team at the specialty unit or at the hospital. And the issue is really about coordination. And I think that the fact that we community pharmacies are considered and are integrated in the care process is about not having missed opportunities. And complement each other. It doesn't mean that we are substituting or that those types of services are not needed, or but we are acknowledging that not all people have access to those kind of services, or that they might find it easier to talk to their neighborhood pharmacy for this kind of solutions. So this is us getting our foot in the door, telling we are also here and we can also be part of a viable solution.
I don't know if she heard you. She said thank you. That sounds like an excellent program.
Thank you.
If I'm allowed, I have one last question. So I think from a practical standpoint, how did you approach the pharmaceutical industry to get started with this? Because I think, you know, that's the big hung up. Once you're in the groove and you have a couple of companies on board, then it's easier for others to join. But how do you start such a process? Is it through a personal connection and people believe in you, or how does it come about?
Yes, most definitely. You have to first reach out to the low-hanging fruit. So people you know, and the needs that you know that the pharmaceutical industry is having, or that you anticipate that they will face in terms of, for instance, regulatory challenges or entering the market with a new drug. And we were opportunistic in those respects. We identified some challenges and we went to the pharmaceutical industry and said, well, we know that you are about to launch this drug, or that you are having problems getting reimbursement for this drug. Well, we have a solution for you, so we can get data from the process, and we, at the same time, we will be impacting positively the individuals that will be included. And that's how we started. And most definitely, having personal connections is important. People that already know that we are individuals they can trust is important. So basically, that's what we did. We used our personal connections, and afterwards it was a matter of starting to present the results. So we went to several conferences. We are going to several conferences, presenting posters. So we are making ourselves known to the pharmaceutical industry for these programs.
And for those of you who don't know, Dr. Paulino's team actually won the Pharm Talks at APHA last year.
This project, yeah.
Yeah. Any other lingering questions, anyone? Don't see anything in the chat. We are at the top of the hour. Thank you so much for this presentation. It was great